Good evening, Gauri Shankar.
Good evening, sir.
I am trying to contact you, but I am not able to get you.
Sir, நீங்க உலகம் சுற்றும் வாலிபன் sir. இங்க வந்தோடனே will definitely sir.
Okay.
Sir, good evening, sir.
Oh,
Good evening,
Dakshani ma.
Dakshani.
Good evening.
Sir, good evening.
Sorry,
Sorry, Yes, sir.
Surprise, surprise voice.
Velur vanditen, sir.
Engama?
Sir, I moved to Velur, sir.
Parmati Velura, Rai Velura ma. There are two Velurs. Which Velur is this?
Katpadi Velur.
Katpadi Velur. Good evening,
Oh,
ma'am.
nice.
Good evening, Dakshani.
Good evening, Dr. Dakshani.
Good evening,
Congratulations.
sir. Good evening, sir.
Rashmi madam, good evening.
Good evening, sir.
Good evening, Gauri sir.
Good evening, madam.
I think start பண்ணிடலாங்களா?
Please.
Okay. ஏன்னா நீங்க நிறைய பேர் I think பிரசிடென்ட்டும் ராஜன் சார் ரெண்டு பேரும் ஜாயின் பண்ணல. So we'll start. Good evening, everybody. It's glad to be back with all of you for the this is the sixth, isn't it? It's the sixth 4th series of the year. Very useful presidential action plan, part of the presidential action plan, coordinated by the Academy of Pediatric Sciences, EAP Tamil Nadu, Dr. K. Rajendran, of course, the convener of this particular program, Dr. Ashwath. Let's start with the pediatrician prayer. Over to Dr. Dakshani for the pediatrician prayer, please.
குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் எங்களுக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்புரிமை என்பதை பணியுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றவும், நல்லனவற்றை உள்வாங்கவும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
Thank you, Dr. Dakshani. This 4C series basically is the brainchild of Dr. Suresh Balan, who wanted to give opportunities to all the peripheral regions of Tamil Nadu, not only the major cities. And the idea was to go for a crisp clinical case capsules where we discuss the common cases and sometimes uncommon as well, and then kind of go through the whole process. So it's kind of having a gist of really interesting cases. And today we have the package on recurrent respiratory tract infections. Because Dr. Suresh Balan and Dr. Rajendran both of them are traveling right now, I think one from Mumbai to Chennai after attending the National CAP program on immunization. I now request Dr. Ashwath to take over the stage. I'm very happy today to welcome our experts on the field, Dr. N.C. Gauri Shankar sir from Chennai, and of course Dr. Anthony Terence. My thanks to all the 4C series team of Dr. Sridevi Narayanan, Dr. J. Balaji, Dr. R. Palniraman, and Dr. Raji, of course, Dr. Ashwath, who has puts in a lot of effort every month to make sure that it happens. Of course, last week we couldn't have it because of the SDM, but we are back on track again. And my special thanks to all the presenters for the day. Over to Dr. Ashwath for starting the session. Thank you, Dr. Ashwath.
Thanks for being a pillar of strength and support to us and making sure this is as glitch-free as possible. because the schools have reopened and monsoon has set in over Kerala, we anticipate a sharp uptick in the number of respiratory infections. So almost all the recurrent respiratory infections start with innocuous problems, and then over a period of time, they become problematic cases. So we are delighted to have a panel of experts in the form of Dr. Gauri Shankar and Dr. Anthony Terence, whose names know the introduction to the people, the doctors of Tamil Nadu. Both of them are doing their very best to put pediatric pulmonology on the Indian map, and they are our source of inspiration and extremely knowledgeable in their fields. Without any ado, I would request the first presenter, Dr. Sharanya Devi, if she's ready to start her presentation. Very briefly, the discussion will be kept to minimum number of slides. We will take periodic breaks from the slides to have the experts' comments. And it's my pleasure to invite Professor B.R. Ravikumar, who is a doyen of pediatric surgery in the world and in India. We are blessed to have him with us. Welcome, sir, to the show. Sir, at this age, is one of the most updated and most well-informed, I should say, pediatricians. He's more of a pediatrician than a pediatric surgeon. So he was very keen to educate us on the role of a pediatric surgeon in children who come with recurrent respiratory infections. So when the time is appropriate, we will take a small break from the 4C series and have sir's inputs on when to refer these children and what is the role of a pediatric surgeon in offering relief to children with recurrent respiratory infection. So this is the bonus for all the people who have tuned in today. Without further ado, let me start with inviting the first presenter. Dr. Sharanya Devi, are you around, ma? Dr. Sharanya Devi.
Saranya.
Good evening, sir.
Are you ready to share, ma?
Yes, sir.
Yeah. And a special word of thanks and congratulations to Dr. Balaji, Dr. Sridevi, Dr. Paniraman, Dr. Raju sir, for consistently being a source of support and always generating course material so that we never run out of case scenarios to discuss. My sincere thanks to all my fellow people in the 4C series. It's a team effort. It's not a one-man show. Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
Dr. Sharanya, start, ma'am.
Sir, host disabled participant screen sharing.
If you have a glitch, can we have the next presenter, ma'am?
Go ahead, Dr. Sharanya. I think you should be able to present now.
You've been assigned a co-host status now. I think you can do it now. Perfect, ma'am.
Good evening, sir. Myself, Saranya Devi, postgraduate, Dharmapuri Medical College, sir. Thanks to Dr. Ramesh Babu, sir, and thanks to Dr. Balaji, sir. And special thanks to Dr. N.C. Gauri Shankar, sir, HOD Pediatrics, Mehta Hospital. 3-year-old boy came with complaints of...
Ma'am, we are not able to see, ma'am. You have to speak.
Doctor, you need to go out, come back, like you need to open out the PowerPoint presentation and then you join and then you share your presentation. Otherwise, we'll not be able to. Usually this is what happens.
Dr. Sharanya,
Sir?
you can open your presentation, minimize it, reduce the screen, and once you are getting the screen share option, click on the presentation. It will come so that we can see. Right now, we can only see your diagnosis.
Dr. Sharanya, can you just accept my request for access to your computer? Can you just accept?
Okay.
Just 1 second. Yeah.
So So can we have the next presenter then? We are facing.
Yeah, we can, you'll just stop it and then we can try again.
Dr.
We'll move
Sashi
on to the
Anand.
next one.
Dr. Sashi.
We have
Dr. Sashi Anand.
Yeah, it has come now. Okay.
This is Dr. Sharnya screen.
Yes, sir. Saranya.
Dr. Sharan,
Yes. Yes, ma'am. Yeah, please go ahead, ma'am.
Okay.
Start, ma.
Sir.
Start with first slide, please.
Yes, sir. So 3-year-old boy came with complaints of fever for 5 days, cold and cough for 7 days, and breathlessness for 2 days, sir. History of presenting illness, history of fever for 5 days, insidious onset, progressive and intermittent high-grade fever relieved by antipyretics, cold and cough for 7 days, insidious onset and progressive not increased by lying down or supine position. History of breathlessness for 2 days. History of dullness of vomiting for 2 days. Usually the vomiting preceded by cough. No history of contact with tuberculosis. The third born child, parents of non-consanguineous marriage, previous two siblings are alive and healthy. Past history of child had inpatient management of pneumonia for 4 times from 6 months of age. Also, child had OPD-based treatment for respiratory tract infection frequently. Developmentally normal child. The child immunized up to the age as per IAP immunization schedule. On examination, baby conscious, lethargic, dyspneic, febrile, pallor, no lymphadenopathy, oral cavity normal, upper airway normal, no dysmorphic faces. Vitals, heart rate 124 per minute, respiratory rate 50 per minute, SpO2 90%, peripheral pulse felt well, CRT less than 3 seconds, weight 12 kg, it is weight for age is above 85%. On systemic examination, CVS S1, S2, no murmur, respiratory system, bilateral air entry plus, bilateral crux plus, subcostal retraction, intercostal retraction plus, per abdomen soft, liver span of 7 centimeter. In CNS examination, tone normal, reflex normal. On investigation, CBC shows neutrophilic leukocytosis and peripheral smear shows microcytic hypochromic anemia, CRP positive, which is 30, chest X-ray suggestive of bronchopneumonia, echo normal, TB screening, Mantoux test negative, gastric aspirate for CBNAT negative, HIV screening negative.
Dr. Sharanya, you
Sir?
can take a break and stop with the previous slide, ma. Can you go? Yeah, right. Dr. Gauri Shankar, can you please educate us on what is the current definition of recurrent pneumonia? Does it matter whether it's viral or bacterial? Do we take the patient's words for definition of pneumonia, or do we have to have some sort of lab, or because everybody says so when does it become a significant issue? When would we be worried as primary care pediatricians?
Yes, good evening all. Thanking you for the opportunity. Like recurrent pneumonia, like we always correlate any finding parenchymal shadows in the X-ray, we always term it as pneumonia, whether it's bacterial, viral, chemical, or anything else. We always use radiology for making a diagnosis of pneumonia. So without imaging, at this point of time, probably we cannot say whether there is pneumonia or not, just with clinical findings alone. So that is number one. 2 episodes of pneumonia. Pneumonia means you have a radiological evidence with clearance in between in 1 year time, or more than 3 episodes of pneumonia. Pneumonia means radiological finding in it is not defined over a period of time. Like any child who has got more than 3 episodes of documented pneumonia, you call it as a recurrent pneumonia. either 2 episodes within 1 year or 3 episodes in their life. You call them as pneumonia, recurrent pneumonia. That's number 1. Number 2, like for any radiological shadow, our opinion is, yes, this child will need antibiotic, we give antibiotics. Most of the time, what they say, like child has chest, phlegm in the chest, probably they attribute to the moist cough which the child experienced. When anyone vomits, we vomit out, like the child after a cough vomits out whatever secretion is there in the esophagus and stomach, and you are going to have the mucus coming out, the mucus lining the GIT. They attribute it to only the phlegm in the chest. It's a misnomer, or it's a wrong notion. So unless and otherwise they have radiological evidence, we will not be able to confirm whether it's a recurrent pneumonia or not, just by the patient's word. This is on one side. On the other side, any child who is going to develop it within the first 6 months or even less than 1 year, 2 episodes with radiological evidence, is there anything going wrong? Less than 6 months, we always think of anything beyond lung, other system involvement, cardiac, probably immune system, probably like aspiration, neurological, especially in the first 6 months. Beyond 6 months, probably like slowly, these things get overtaken by viral infections. So when did it start first is one thing. And if you are going to have a child like this who had 4 admissions for pneumonia, probably like in the general exam, I would like to look at the throat, look at the tonsil, because in immune deficiency, even before we do any investigation, general examination is looking at the throat, how the tonsils are, whether it's absent or not, because these give clue. Second, into the ear, like either perforation or otitis media, then lymph nodes, liver spleen. Like you can have a well child who has got a recurrent pneumonia. Probably this may be related to even environment. A child who is not thriving well, who has got a pneumonia, or a child who has got recurrent pneumonia early in their life, these 2 categories, those who are not thriving well and those who have recurrent pneumonia early on in their life, I would like to definitely investigate further, rather than a healthy child who does not have other features of like growth retardation, who does not have much, other system involvement. This child can be followed up, but in a child who is not thriving well and early onset, you need to definitely do investigation, try to find out what's happening.
Sir, you made one very particular point saying that there should be complete radiological clearance between 2 discrete episodes. Am I right, sir?
Yes, please.
So, but we routinely do not take a repeat X-ray after treating a pneumonia. So how do we know this complete resolution? That is not the teaching also, no, sir?
Usually, guidelines say what is practicable for most situations in a general condition. But when you are looking after the child, our clinical signs, especially when a child has got a pneumonia, how many times you can hear a bronchial breathing? Definitely not. The child may have like features of pneumonia radiologically, but we don't hear a bronchial breathing. There is always a gap between our auscultatory finding and what is seen in the X-ray. Smaller the child, we always think about radiation causing a problem. Yes, that should be in the back of our mind. But in a child who is not thriving well, who has already had a previous episode of documented pneumonia, if the child comes to you for the second time, probably it is time for you to have an X-ray at least 1 month after the first X-ray, so that at least you have a documentation. If the child gets into a problem, next time once again it becomes a problem, whether it is a continuation of the same or whether it's a new one. Unless you have a radiology, you may not be able to document this child has This is one side. The other side, whether you can make out everything clinically, definitely X-ray is a extension of clinical exam as far as respiratory system is concerned, because most of the time as practitioners, how many times you are able to make out a pneumonia just clinically? Definitely with some difficulty only we'll be able to. You need to count the respiratory rate for 1 minute. You should not have a wheeze. The child should be calm. So many things are there. So the easiest way to get out of this situation, yes, at the end of 1 month, if you have a significant mnemonic change in the first X-ray, kindly repeat. This is my advice after being in the clinical side for more than 30 years.
So you would suggest that documentation of the clearance of the pneumonia is important to say this is not an extension of the primary pathology and we have a new problem. The age of the child and the fallibility of the clinical signs. Point well taken, sir. Thank you. Dr. Anthony, are there pointers in the history that you would want us to look at in every child who comes with recurrent pneumonia? Are there pointers in the history?
Yeah, I think at the outset, I would like to thank, the team who is organizing this program and my teachers, who's already there. It's a privilege to be part of this meeting. And if I put myself in the shoes of a practicing pediatrician, who is seeing, 50 to 100 patients, I think I would like them to follow a traffic light signal kind of thing, when our children come with recurrent infections, if we can have a green zone, or a green child is, in the green zone, is a healthy child, and having just a viral respiratory infection which resolves the usual time period of 1 or 2 weeks. And, that's a healthy child having recurrent infection. And we can have about children can have about around 4 to 8 infections per year. And usually most of the infections are upper respiratory infection. And second thing is children who has atopy, and these children can also have respiratory infection, but there will be definitely strong family history of atopy and atopic markers. This is yellow for me. And I think these children also need some time, because of atopy, children can have recurrent infection because there is already mucosal inflammation, increased permeability, as well as an adherence of bacteria and virus more in children with atopy, and their immune system is not very effective compared to a healthy child. Therefore, you have to isolate healthy children with recurrent infection, and yellow zone will be a atopic child with a recurrent infection. Finally, the red zone. We have to identify children who are in the red zone. They probably constitute about 10 to 20% of all recurrent infection. And as you asked me, we have to look for red flag signs. We have to look for red flag signs. Important red flag sign is growth faltering. Okay, and if the child is not thriving well, definitely that will be my important thing. Therefore, it's important to plot the children on the growth chart. That's very important. And other red flag signs is common for all respiratory problems. Any symptom onset from the neonatal period. It could be a congenital malformation or some genetic cause. Neonatal onset symptoms. And if there is cough, if it is a wet cough, probably that might indicate child might having a suppurative process, early onset wet cough. That's a red flag for me. And feed-related symptoms. It could be some aspiration syndrome causing recurrent chest infection. Therefore, any feed-related symptoms. And when we talk about feeding, failure to thrive as well, any failure to thrive. And it's very, very important to look at the hands. Sometimes we miss the hands and treat like the ordinary thing. If you look at the hands, look for clubbing. In all children with respiratory problems, look if there is any clubbing. It could be chronic suppurative lung disease presenting with recurrent pneumonia, recurrent chest infection. Clubbing is very, very important. And also when you listen to the chest, you have to look for differential air entry, whether the air entry is good or not. It's important to look for vesicular breath sounds and other things. It's important to look, the gross thing will be the air entry, because I had patients with retained foreign body presenting with recurrent chest infection. Therefore, differential air entry, that's very, very important. And airway malformation, vascular compressions, they can present with monophonic wheeze or stridors. Therefore, if there is a wheeze, it's important to qualify whether it's a polyphonic V's or a monophonic V's. Children is very, very important. Another thing is like opacities. If you look at the opacities, if it is unusual, as has said, like if the child has persistent symptoms, unusual opacities, definitely is important to do a repeat chest X-ray of 4 to 6 weeks. Especially I do for children who have persistent symptoms. If it is a round pneumonia, I do, because these children can go for lung abscess, and any complicated pneumonias like empyema, definitely you need to take a repeat chest X-ray. Therefore, if it is persistent opacities, you have to be on the you have to be a bit careful. And hypoxemia as well, with persistent hypoxemia. These are my red flags. And the most important red flag is putting them on a growth chart and plotting the weight gain. That's very, very important. And therefore, in a busy clinic, you can follow the traffic light signal, green, yellow, and red. And even in the green zone, if the child is presenting with recurrent, chest infection, we have to look at factors. If there is anybody smoking at home, what about the immunization status of the child? Is there any overcrowding? Is the child going to a school which is very crowded? Are there any modifiable risk factors? We have to identify those risk factors and try to, correct those risk factors even in the green, for children in the green zone. For yellow zone, I think you have to spend time with children about inhalation therapy and all those things. For red zone, definitely, I think if you have facilities, you evaluate, otherwise send to a place where it can be evaluated. I think I have deviated a little bit from your question, but I've answered your
point is taken. The point is well taken, Dr. Anthony. We are learning a lot. Please go. So the point I'm making is the age of onset, the fact that the child is not growing well, subtle markers like differential breath sounds, persistence of symptoms rather than recurrence, growth failure, subtle pointers like clubbing, failure to thrive, hypoxemia, low saturations in room air, child is unwell between the episodes. All these are the red flags that you want us to remember when evaluating children with recurrent respiratory infection. Thank you so much. Dr. Sharanya, you can proceed, ma'am.
Yes, sir.
Dr. Sharanya?
Yes, sir.
Next slide, ma'am. Please tell us what this patient had.
Nasal water through nasal pharynx, IV fluids, and IV antibiotics given or injection ceftriaxone for 7 days, and oral azithromycin and support.
Can we have the next slide, Dr. Sharanya? Your slides are still stuck in the investigation slide. Can you move on to the next slide? Probably needs an expectorant to move.
Sir, shall I?
Okay, ma'am. You can tell us what you did. It doesn't matter. If there are any important X-rays or investigations, you could highlight them at the end of the presentation. If you have the material with you, you can please share.
Yes, sir. Treatment given or nasal O2 through nasal pharynx and IV fluids, IV antibiotics for 7 days, sir. Ceftriaxone given for 7 days, and oral azithromycin and supportive care, sir. Course in the hospital, the child general condition improved, distress decreased, afebrile and taking feeds. The differential diagnosis for recurrent respiratory infections are congenital heart disease, tuberculosis, and pathological GERD and cystic fibrosis, immunodeficiency. For this child, immunodeficiency is in view of a recurrent respiratory tract infection, the child was referred to Maythaw Children's Hospital for pediatric pulmonology opinion and worked out for primary immunodeficiency. Whole exome sequence was done. The diagnosis come out as Bare lymphocyte syndrome type 1 due to TAP2 deficiency, sir. The Bare lymphocyte syndrome, which is a rare genetic autosomal recessive immunodeficiency disorder. Bare lymphocyte syndrome usually caused by mutation in TAP1, TAP2, TAP-BP genes. Mutated gene impacted transport of peptides in endoplasmic reticulum. MHC protein broken down and lead to shortage of the MHC protein in the lymphocytes. It leads to impair the body immune system to respond to bacteria, skin ulcer, rarely chronic diarrhea. The treatment for Bare lymphocyte syndrome is bone marrow transplantation. For this child, bone marrow transplantation done 2 weeks before. So, thank you for
Dr. Shania, can you go back to your differential diagnosis slides?
Yes, sir.
Dr. Gauri Shankar, sir,
Yes.
would you care to comment about this, sir? Would you consider tuberculosis as a cause for recurrent respiratory infection, or is it a cause for a chronic respiratory infection, sir?
No, I will definitely put TB in the background, but not as what to say, number two. Probably aspiration would have been first for me because 4 admissions, pneumonia, I think documented with X-ray. So definitely, like I'd like to think in terms of an aspiration. That is number one.
Sure.
Second, cystic fibrosis, probably if there is no clubbing and no oil in stool, probably history, like no oil in stool, probably like not much wet cough in between except during the episodes. I will even put cystic fibrosis as the lower, like not in the 4th place. Probably because it started at 6th month and more than 4 episodes till 4 years, like needing admission. Probably like I'll put first as immune deficiency because everything started after the 6th month. So first 6 months, nothing happened. Child was gaining weight and even the weight gain was good. So not much of a problem, but something is not all right with the fighting power of the body. So I will like to think in terms of in retrospect only as immune deficiency as the first possibility. But in our country, yes, we need to rule out TB, but TB will not present like different lobes at different times. It is something like if you don't diagnose, it's going to keep on progressing. It may not fully settle down with whatever antibiotic, because nowadays the antibiotic choice, what we see in the prescription is always a higher antibiotic, even if it is not going to have a continuous flow, but it may not be like the antibiotics what like people give may not be able to control the TB infection. It's going to continuously progress and child is not going to be well in between. Probably like I will put the immune deficiency as the first one, aspiration as second, third will be any anomaly in the intralumen of the tracheobronchial tree. I would like to, because the more we look at more findings, like more tumors we are looking at, like carcinoid, leiomyoma, like we do have like specifics in the intraluminal tumors, even though endobronchial TB is one of the commonest, we do see rarer things. So probably the order in which the differential diagnosis, my choice will be slightly different, because exclusive respiratory practice, we tend to probably over investigate. That's number one. And we tend to look at the rule out the bad things first, rather than trying to look at the good things as the first thing.
Thank you, sir. Dr. Anthony, could you suggest us some tiered investigations which everyone can do, and then investigations where you will do in special situations, and investigations which will be done as tier 3 investigations in a child with a similar history, recurrent proven bacterial pneumonia like Dr. Sharnya presented?
I think Sarah has outlined all the important points, but the first investigation will be chest X-ray. Chest X-ray will give lots of clues, like it can say like whether it's a unilobar or multilobar. It's important to go through serial X-rays. It's a unilobar, it's very easy to make a diagnosis. It's usually going to be a parenchymal or airway malformation. And if it is a parenchymal, it's going to be like a sequestration or CPAM. And, it's easy to make a diagnosis CT scan. And if it is airway, it's going to be some vascular compression, or a bronchomalacia or a foreign body. These are the things you look at. Therefore, I think looking at the X-ray, serial X-rays will give a clue. It's a unilobar or a multilobar. Unilobar, with the CT scan and bronchoscopy, will be able to make the diagnosis. It's very easy to make a diagnosis with a unilobar. If it is a multilobar, probably I think it's very difficult, to tease out. But there will be some clues, and usually go in order. In a multilobar pneumonia, usually it's important, to identify the bug. Lots of times there will be signature organisms. Like in case of cystic fibrosis, if you have Pseudomonas, sometimes children come with severe pneumonia and get intubated, and we get if the secretions are positive for Pseudomonas burkholderia, it's a signature organism for cystic fibrosis. You'll be able to make a diagnosis. Therefore, if you identify signature organism, especially your immunodeficiency, if you have organisms like pneumocystis or CMV, or fungus, probably it's easier to, or catalase positive organism, you'll be able to make a diagnosis. Therefore, try to identify the bug. Therefore, if in an older child is a bit easier, but younger child, again, it's going to be difficult. If a child is intubated, it's very easy. Otherwise, it's difficult to get the organism. Therefore, try to identify the bug. That's my first thing. And second thing is, look at the defenses of the patient host. Look at the defenses. Look at the defenses in the sense mucociliary clearance. Therefore, in mucociliary clearance, cystic fibrosis, as I said, most of our patients, 90% of our patients will have the triad of recurrent or persistent chest infections, failure to thrive, and oily stools. Therefore, if you have the triad, most of the time patients won't come out with the oily stools, but you have to ask the patient, or else you have to look at the stools. Therefore, if you have this triad, usually they present within the first 1 year. Actually, if you don't identify them, they will die as some severe pneumonia, sepsis. Therefore, this triad is very, very important. Identifying this triad. In PCD, other mucociliary thing, we look at the 4 things actually. Whether the child has got unexplained neonatal respiratory distress. I usually tell 3 L's. 3 L's in this respiratory distress. One is late onset. Normally TTN or some other respiratory distress, usually the onset is within the first 12 hours, but here it's a bit late. So usually respiratory distress starts later, later than 12 hours. And X-ray, if it shows lobar collapse, especially upper lobe collapse, that's another indicator. And respiratory distress in a PCD could be long-term. In TTN, it usually settles within 48 hours. This takes more days. It might take weeks. Therefore, if you identify the 3 L's with the respiratory distress, probably you are dealing with the PCD. And the second thing is about 40 to 50% of patients can have situs or organ laterality defects. Therefore, it's the least common of all the findings, but if you have that, you'll be able to make you can suspect. And absence of situs inversus doesn't mean the child doesn't have PCD. And second thing is, any child coming with persistent, purulent nasal discharge, மூக்கு எப்பவுமே திக்கா அடைச்சிருக்கு, chest infection ஓட ஒரு child மூக்குல எப்பவுமே சளி இருந்துட்டு இருந்ததுன்னா most likely to be PCD, purulent nasal discharge, because they have mucociliary clearance problem, which is there in the nose and the chest. Therefore, persistent wet cough and persistent purulent nasal discharge, out of these 4, neonatal respiratory distress unexplained, second thing I said, organ laterality defects, persistent wet cough, and then purulent nasal discharge. Out of these 4, if you have 2, we can make a provisional clinical diagnosis of PCD. Therefore, these 2 disorders can be easily clinically diagnosed, by their pattern, by your pattern recognition. You easily identify. If you see 2 or 3 patients, you'll be able to identify by pattern recognition. Next comes your immune deficiency. I always say, before evaluating for primary immunodeficiency, look at for common conditions that for secondary immunodeficiency, malnutrition, as well as HIV. Therefore, before doing expensive tests for primary immunodeficiency, do that. Sometimes you will be surprised. You might have HIV, or that's very important. Before primary, go for secondary. Primary immunodeficiency, you have 3 things you look at: age of onset, again organ involvement, and bugs. Based on that, you can identify which component of your immune system is involved. Usually, we have 4 components: innate 2 and adaptive 2. Innate, we have phagocytic function and complements, and adaptive, we have your humoral and T cell immunodeficiency or combined immunodeficiency. Therefore, you'll be able to identify age of onset, the bug, as well as organ involvement. Therefore, in immunodeficiency, usually it's a multilobar pneumonia, and there might be some markers in other organs as well. It's not one organ, usually the other organ as well. Therefore, in a patient with, persistent pneumonia, if there is failure to thrive, if there is a oral thrush, then you have to think about absence of BCG scar, absence of lymph nodes in the presence of infection. That again, a marker. Especially lymph nodes means I also mean tonsils, absence of tonsils. You are not palpating the lymph nodes, and you don't have a BCG scar. This is very important because these children might present with anemia. What we do is sometimes we give blood transfusion without knowing these children have primary immunodeficiency. Therefore, we are creating artificial disease in those situations. Therefore, we have to, any child with severe pneumonia, severe or recurrent pneumonia, before giving any blood transfusion, think about immunodeficiency. The most important thing to look at, I think is the slide is very important. The investigation slide. Can we go back on the slide? Go back on the slide. The investigations.
Saranya.
Therefore,
Dr. Sharnya.
Dr. Saranya.
Yeah, it's okay. It's okay. Therefore, here it was mentioned that
Yes,
the investigation. It's important. We have to look at the neutrophil count, whether neutropenia or neutrophilia. These two things are very important. Very high neutrophil count. You can have with your phagocytic functions, especially CGD or LAD, you can have neutrophilia. And we also see lots of neutropenic children, congenital neutropenias presenting with pneumonia or other infections. Therefore, you have to look at the absolute neutrophil count. It has to be more than 1,500. And other important thing, especially in younger kids, is to practice looking at not only the neutrophil count, lymphocyte count, okay? And lots of kids we have identified by just looking at the counts. If you look at the count, if it is less than 2,500, absolute lymphocyte count is less than 2,500. And it's not one time or a couple of times, probably you have to go and see your chest X-ray. That's very, very important, And absent thymus, or if you look at the thymic shadow, if it is not there, these are two important clues to pick up SCID in a very young child. Therefore, lymphocytopenia as well as your thymic shadow on a child. These are two important clues to pick up cell-mediated immunodeficiencies. And third thing is we also look at the platelet count, thrombocytopenia, skin rash, Viscott-Aldrich. Sometimes recurrent infection, eczema, thrombocytopenia, Viscott-Aldrich. Therefore, CBC and chest X-rays and the clinical, presentation, you can make out, SCID. That's very, very important because your treatment is going to change dramatically, and you are going to make an early referral to a center where they can manage the SCID. Because if you keep on giving antibiotics like community pneumonia, the child is going to worsen and it's going to be difficult to treat or do bone marrow transplantation. Therefore, whenever a child presents, try to make an early diagnosis the child has got SCID. These are some clues for your immunodeficiency. After immunodeficiency or defenses, I'll look for the neighbors especially aspiration syndromes, feed-related symptoms. Aspiration symptoms we commonly see, especially in children who have neuromuscular diseases, especially some neuromuscular disease. It could be cerebral palsy or some muscular dystrophy. These are the children who are swallowing dysfunction and aspirate frequently. And this other group, what we see is some children having anatomical problems like cleft palate or tracheoesophageal fistula, or if the child has got some anatomical problems associated with GRD. These are the children who can present it aspiration symptoms. These children usually have feed-related symptoms, or they can have neuromuscular issues. Therefore, it's important to look at the muscle tone development of the child in a child with recurrent chest infections. Okay. And these are the commonest group. And finally, we have to ask about foreign. Don't forget foreign body. There are children can present either localized pneumonia or a migratory foreign body can present like a multilobar pneumonia, foreigners, and others. There are mimickers. Okay, therefore, a child presenting recurrent chest shadows, okay, it's important to look at the hemoglobin. If it is dropping, it could be pulmonary hemocirrhosis. It's a mimicking condition. You might be treating as pneumonia. It could be something else. I have treated a patient with the TAPVC, again, a neighbor, like a cardiac problem, multiple, different times, different opacities in the different portions of the lung, TAPVC. And sometimes echo can miss. If they do a fast echo, they can miss. Therefore, you have to document all the pulmonary veins where they are draining. And it's very important to ask the cardiologist whether they are missing anything. Therefore, these are the things. One is like as I said, try to identify the bug. Second thing is like look at your defenses, the mucociliary apparatus and the immune system, and then your neighbors, especially aspiration syndromes, cardiac problems, and foreign bodies and foreigners, and then others. Others are pneumonia mimicking conditions that we might miss.
Thank you so much. This is a first case scenario. We have 5 more cases to be discussed. So I would request the comments to be very brief from here on, because it's a first case and we have to set a platform for the rest of the discussions. We had a lot more time available. I would request both the moderators to be more brief in their answers, because we'll be running short of time. Thank you so much for your elaborate answers, nevertheless. Can we go on to the next presentation? Dr. Aisha? Dr. Aisha?
Yes, sir. Can you hear me?
Can you start screen sharing, ma'am?
Oh, yes, sir.
Dr. Gauri Shankar and Dr. Anthony have beautifully laid the stage for us to have a pattern for recognizing, and then they've also told us what are the basic investigations which every child should need to have done, and what are the points at which you would start suspecting differentials which are not pneumonia, which are pneumonia mimickers. So now that we are armed with some amount of basic knowledge, we can probably have more speedy discussions for the forthcoming cases. Yes, Aisha, you can start screening.
1 second. So can you see my screen, sir?
Yes, you are audible, you are visible. You can start screen sharing and proceed.
Okay. Good evening. I'm Dr. Aisha Sultana, DNB resident KMCH. Good evening to my teachers and doctors.
Please go to the slide share option, please.
I'll be presenting a case about an 8-year-old male single child, Mithuneus, born of 4th degree consanguineous marriage. He was brought with complaints of breathing difficulty for 1 day and low-grade fever for 1 day. Coming to the history of presenting complaints, his breathing difficulty was of about 12 hours duration, which was acute in onset and progressively became severe. His fever was for 1 day. It was also acute in onset and it was low-grade in nature. This episode was not associated with cough, nasal discharge, aspirations, or vomiting. He was not currently on any preventer or reliever bronchodilators, reliever therapy. No history of frequent episodes. He had history of frequent episodes of sneezing, especially at morning after getting up. He also had history of intermittent cough with fever episodes in the past. Coming to the negative history, there was no history suggestive of any aspiration. There was no history of palpitation, chest pain, bluish discoloration of nails, fingers, or lips. There was or swelling over eyes, legs, abdomen, or syncope. There was no history of feed-related symptoms like coughing or regurgitation. He did not have any history of recurrent sore throat or pain during swallowing. He did not have any snoring or drooling at night, and he also did not have any history suggestive of recurrent ear infection or sinusitis or pharyngotonsillitis. And also, he did not have any previous history of any harsh, brassy cough with stridor. He did not have any history of recurrent diarrhea or altered consistency of stools or altered bowel habits. He did not have any previous history suggestive of extrapulmonary infections like skin infections or abscesses. There was no history of failure to gain weight or any loss of weight. He did not have any history suggestive of contact with TB. His immunization history, he was immunized up to 1.5 years of age. Birth history, it was a term delivery. Birth weight was around 3.7 kgs, and the baby cried immediately after birth. His neonatal period was uneventful. Development is, he was a well-thriving child. He was appropriate for age, and he was also actively involved in sports activities in school. Family history, there was a history of wheezing issues in paternal grandfather. There was no history of inherited disorders in family, no history of sibling death. Coming to personal history, there was history of exposure to smoke from iron casting industry near school, and he also had a pet dog at home. Past history, prior to this admission, just 15 days before, he was admitted with fever and rashes, and he was treated as para-infectious urticaria. Coming to his past history regarding his respiratory infection was very significant. His problems started at 1.5 years of age. At first admission, he had fast breathing and fever. He was admitted and treated at outside hospital and treated with nebulization. He was probably treated as a case of Valerie. At 5 years of age, he presented to us first. He came with a history of alleged submersion in a swimming pool. After that, after 3 days, he developed nasal congestion, cough, and then an acute onset of breathlessness. At admission, he had a respiratory rate of 40 and room air saturation of 98%, and auscultation revealed bilateral basal crepitations with mild wheeze. His blood investigations were not that significant. He was treated as a case of aspiration pneumonia with nebulization and supportive management. The next admission was at 7 years of age. This time also he presented to us with fever for 3 days and cough for one week. And again he had a acute onset breathing difficulty for 1 day. At presentation, he had a respiratory rate of 35 and a room air saturation of 92%. And on auscultations, predominantly right-sided Krebs was present. And we had taken an X-ray. It showed right-sided infiltrates more, and his blood investigations revealed elevated total counts with polymorph predominance and a CRP of 67. So he was treated as a right-sided pneumonia with IV antibiotics and other supportive measures. Next admission was next year at 8 years of age. He had presented to us with cough, purulent nasal discharge for 2 days with low-grade fever. Initially, he was treated outside with nebulization in another hospital. There, he developed sudden onset of breathlessness for 6 hours, and he was referred to us. So at admission, he had a respiratory rate of 65 and a room air saturation of 80%. What was noted was that there was increased efforts of breathing, but his respiratory movements, his thoracic movements was found to be weaker than of his abdominal muscle movements. Auscultation also, there was bilateral Krebs and bilateral wheeze. Since the baby was in respiratory failure, we had shifted, he required PICU care. So at PICU, he was managed with PICU care. PICU, he was managed with NIV supports, antibiotics, and bronchodilators. He could be weaned from NIV only on day 6. What was noted was intermittently he had poor respiratory efforts, and it was not easy to wean him of oxygen. And in view of his history of recurrent right-sided pneumonia, we had to rule out localized pathology, anatomical defects causing recurrent one-sided pneumonia, any airway obstruction or any airway compression, etc. So for that, we had taken a CT scan of thorax. It had revealed patchy areas of ground glass opacities with adjacent atelectasis scattered in both lungs with adenopathy. It was more suggestive of more of an infective etiology. And also we had worked up for any primary immunodeficiencies. We had sent for lymphocyte subset analysis, which came out as normal, and immunoglobulin profile, which revealed elevated IG. In view of his poor respiratory efforts, nerve conduction study and CPK was done to rule out other central or peripheral neurological causes or muscle causes. This was also normal. Then within 2 months, he presented again to us. So this is the current admission that I'll be presenting upon. So at this current admission, general examination, the child was febrile, tired looking, and tachypnic. There was no pallor, icterus, clubbing, or lymphadenopathy or cyanosis.
Dr. Aisha, give us only the relevant findings. You don't have to read everything. What was striking about this child in this current investigation? Only highlight the important features.
Okay, sir. So this time also he presented to us with an acute onset of breathlessness, sir, with the fever history. His presentation, his room air saturation was 88%, and he had increased efforts of breathing. But what was noted was he had weaker movements of his thoracic muscles compared to his abdominal muscles during his respiration. And auscultation, there was bilateral expiratory wheeze with right-sided Krebs. Otherwise, everything was okay, sir. And on CNS, only subtle hand grip weakness was there. No other weakness or anything was there, sir. ENT examination was also normal.
Now we can take a break. Dr. Gauri Shankar, sir?
Yes, please. Like
she's giving the history suggesting that there might be an intermittent neuromuscular weakness causing recurrent respiratory infections. Are we right in that supposition? Does this history worry you, sir? Or why should we be worried about this child?
Only thing, first question, whether the weakness was more in the evening time or more in the morning time, or it was the same throughout. So if there is going to be a difference in the morning and evening weakness or the respiratory effort, probably we need to go towards myasthenia and what is causing a myasthenia, like picture. That is number one. Number two, they are always say that the thoracic muscles, the efforts are weak. Is there anything in the center, in the spinal, like in the like brainstem level or in the cervical cord, to cause a weakness in the diaphragm, even though they have a cough not only by diaphragm but also by other expiratory muscles? Probably something is there in the spinal level rather than in the lungs to cause this problem.
So you believe that hyperventilation might be of a neurological origin rather than a muscular origin, sir. Is that correct?
Yes, at this point.
And the pattern of weakness, the diurnal variation would probably give us a clue. Dr. Aisha, was there a history? Can you answer Professor Gauri Shankar's queries? Was there a diurnal variation, the weakness?
So while he was while he was admitted in PICU, we had intermittently observed. It was not like diurnal, sir. Intermittently, he had.
And in between these attacks, the child was apparently normal, going to school, attending school without any impairment of locomotion, or
No,
he
sir,
didn't
he was
have
very much
recurrent snoring or aspirations.
No, so he was very much actively involved in sports activities. He's very active child.
Okay. Do you have any more investigations to show us, Ma? What did your final workup come up? You skip the differential diagnosis.
Okay, sir.
What else did you do? Yeah.
We had done one bedside aquagenic Brinkling test. We also did one echo. Everything was normal, sir. In view of we suspected some congenital myasthenic syndrome, so we did a repetitive nerve stimulations test. It was also negative, sir. And then he was weaned off NIV support, and then he became better. We just discharged him on supportive medication. We had sent for a clinical exome, so they had given like heterozygous variant of uncertain significance related to primary ciliary dyskinesia and severe combined immunodeficiency, sir. On follow-up, pediatric pulmonology opinion was taken. So there a pulmonary function test was done. So there it was found that there was significant bronchodilator reversibility of both FEV1 and PEF. And then in view of the primary ciliary dyskinesia, high-speed video microscopy was done. It was also a normal study. So it was opined that it was more primary ciliary dyskinesia was unlikely. Now, currently, the child is on preventer and reliever bronchodilator, sir.
Thank you, ma'am. Dr. Anthony, would you comment? In fact, you're seeing this child. Can you please explain the disparity between the clinical exome findings, which says he has a combined heterozygous defect of suggests for PCD? We have a history which is probably not fitting all the criteria that you told us, in the sense his neonatal period was normal, he's not had persistent nasal discharge, but he has multilobar pneumonias and consistently coming up with distress, needing repeated oxygen administrations and responding transiently to have a recurrence. And you have seen the child and you have done the completion of the workup, and you disagree with the finding of the PCD. Is this possible that you have a genetic PCD and physiologically not PCD scenario? Can you elucidate, please? Dr. Anthony?
This case is nicely worked up and treated, during all the episodes, like child is treated. Sometimes we might not find an answer to the primary problem. This is one of those cases. And, unlike other cystic fibrosis, where there is only one gene, and we are looking at different mutation, is 100% sensitive and specific. We can, if cystic fibrosis, if it is negative, it's negative. The genetics negative, it's negative. If it is positive, positive. But in PCD, there are a Humpty number of genes, like 300 genes. It's not a single gene disorder. So multiple genes are involved in production of ciliary proteins. And so far, we know only about 40 genes responsible for PCD. That if you put together all the 40 genes mutations, 75% of patients only will be able to give a diagnosis. If it is pathogenic, definitely we can say it's PCD. But here it's a variant of unknown significance. Therefore, we are in the dark. Therefore, in these kind of patients, where It's variant of unknown significance. It's not, like the genetic test is telling, basically, I don't know, like whether it could be PCD or it could not be PCD. Therefore, it's a gray area. In those patients where we have to go by the clinical picture, what I have said is if there are the 4 cardinal features, neonatal respiratory distress, situs inversus, early onset persistent wet cough, that's usually within the first 6 months, and persistent nasal discharge. It's not an episodic illness. PCD is a persistent illness. Therefore, the clinical phenotype doesn't fit in, perfectly, but we have to take everything with a pinch of salt. If patient comes later at 7 years, they might ignore whatever happened in the first 2 or 3 years. They might forget. They think, child is, like any other child getting frequent infection. Therefore, we can't go only by, clinical phenotype, but in this patient, clinical phenotype doesn't fit, but it doesn't rule out PCD. And here we have to go with the functional test, whether the cilia is beating normally, nasal nitric oxide. But in this patient, we can see cilia is motile. If it is immotile, then it's easy to make a diagnosis. If it is motile, then we'll look at whether the motility is normal or abnormal. And when you looked at it, it looked absolutely normal. Therefore, we thought it's very unlikely to be PCD. Therefore, VUS is a difficult area in genetics. Therefore, unless we have 100% coverage for PCD, won't be able to tell in VUS. Therefore, you have to go by clinical phenotype as well as the functional test. Therefore, based on both of these, we have mentioned PCD unlikely. I have not mentioned PCD. It's not PCD. It's PCD highly unlikely.
Thanks.
Therefore, what to do in this kind of
case basically highlights the fact that even if you have a variant of unknown significance, we don't have to jump into a diagnosis of PCD unless the rest of the clinical picture is correlating. And most importantly, as Dr. Anthony has rightly pointed out, we have to demonstrate that the cilia are either structurally or functionally abnormal. So just because they have a prime genetic defect on a clinical exam doesn't mean we fix the diagnosis on the child. We can't force the diagnosis. We probably will get more clues as the case unfolds. Thank you, Dr. Aisha. Is Dr. Sashi Anand ready with his presentation? Dr. Sashi Anand?
Yes, sir, I'm ready.
Yes, you can start screen sharing. After this, we'll have Dr. Professor V.R. Ravikumar's presentation on what he believes are important vital things which we should pick up early and refer to a pediatric surgeon. That will be after Dr. Sashi Anand's presentation. Over to you, Dr. Sashi, please. Yes, sir. Thanks, Dr. Aisha.
Thank you, sir. Thank you, sir.
Sir, it's coming host disabled participant screen share.
Aisha, you need to come out, man. Stop your screen share.
Okay, sir. Okay, sir.
So, sir, good evening. Full screen போட சொல்லுங்க அடுத்த ஸ்பீக்கரை. Full screen ஏ வரல.
I made the request, sir, because that will take some more time. That's why I did not.
Oops.
Dr. Aisha, have you quit this program?
Yes, sir. I stopped the screen sharing.
Okay. I'm still seeing your DP.
Sir, it's coming host disabled participant screen sharing.
Thiru, bro, does he need to be made a co-host, or can I ask Professor Ravikumar to make his presentation? Thiru? Dr. Sashi, we can get that fixed up. If you don't mind, can we have the next presenter?
Sure, sir. Yes, sir. Thank you.
Dr. Ravikumar, sir?
Yeah, I am here.
Yes, sir. You can screen share and start your presentation, sir.
Are you able to see my
Perfect, sir. Yes, sir.
Yeah. Right. Then the topic is on surgically remediable causes of recurrent respiratory infection in children. I am not telling you about all the surgical conditions which produce pulmonary infection, but I have chosen a few, just a pictorial illustration. I remember very well about 30 years ago when one of our senior pediatricians, Dr. Muthukrishnan, referred a child for whom we had taken a chest X-ray for paroxysmal atrial tachycardia. Now, this chest X-ray showed evidence of gas shadow inside the pericardium. So he rightly made a diagnosis of very Margagni hernia, herniating into the system and producing paroxysmal atrial tachycardia. So I asked him, how did you make the diagnosis correctly? He said, we have listened to one of the clinical meetings where Margagni hernia was presented with similar findings. So the idea of my presentation is to show a few pictorial slides of children who have been coming to the hospital with recurrent attacks of respiratory infection, initially treated as a pulmonary problem. Subsequently, they are found to be surgically correctable problems. Now, this child with a recurrent respiratory infection and cough during feeding with liquids, very important history. On investigation, it was found to have H type of congenital tracheoesophageal fistula. Now, what investigation was done? The child was sent to a radiologist for cine radiography with water-soluble dye. Don't use a barium because the barium, if it gets aspirated into the lungs, produces a lot of problem. Now, this child had H type of tracheoesophageal fistula. You can find here esophagus, and that's the dye going into the trachea and producing recurrent attacks of right upper lobe consolidation, infection, and fever. Now, subsequently, scopy was done. The scopy also showed evidence of the presence of a fistulous tract, and this fistulous tract was disconnected through a cervical approach. It was totally disconnected. We interposed in between the trachea and the esophagus, the sternomastoid muscle. There will not be any recurrence. Most of them are done by surgical methods because they are present predominantly in the cervical region. A few of them which are present in the thorax need a thoracoscopic approach, or it can be done by thoracic surgery. Now, endoscopic closure of this has been tried with the tissue adhesives, electrocautery, sclerosants, and laser, etc. But it all depends upon the person who has done it, and the results will give you a definitive answer to this above condition. Now, recurrent chest infection also develop like an operated tracheoesophageal fistula. Now, I was in Children's Hospital Egmore, Madras, between 1969 to 1975. At that time, the survival of the tracheoesophageal fistula with esophageal atresia was almost nil. There was only one child who was alive for 6 years. Now we have reached a stage where it is almost about 95 to 100% of tracheoesophageal fistula and esophageal atresia surgery. But the thing is, some of them can have a recurrence of the fistula like this. And when you feed these children, they do develop a recurrent attacks of respiratory infection, especially involving the aspiration into the right bronchus and recurrent pneumonitis. Now, again, these are cine fluoroscopy with the dye being given, water-soluble dye being given, and the picture is taken. Of course, the treatment is surgery while the fistula is disconnected. Now, one of the causes of recurrent respiratory infection of the lung is pulmonary sequestration. Now, this pulmonary sequestration or aberrant development of the lung in which an extra lobe is present, either inside, it's called an intralobar, which is rather uncommon compared to the extralobar. Now, the extralobar can either be in the thorax or extrathoracic region. I'll show you a very interesting case which we saw in PSG hospital by one Dr. Arvind Singhal. He was there. Now he is in Navi Mumbai. Now this child had a recurrent respiratory infection involving bilateral lower lobes. Now the X-ray showed consolidation, the lower lobe region, and then subsequent investigations by doing a water-soluble dye picture showed that the bronchopulmonary segment sequestration, extralobar sequestration, communicating with the trachea and getting repeatedly aspirated and getting infected was the cause of that. This was approached through the left thoracotomy. Through the left thoracotomy itself, both, the things have been dissected out and ligated and removed bilaterally. Now, this has been, of course, published in the Annals of Surgery by bilateral communicating bronchopulmonary foregut malformation. Now, intralobar sequestration, which is rather uncommon, by far it is more common in the left lower lobe in the posterior segment. But the one child in whom a picture like that was seen was diagnosed. It was taken from a different booklet, and then this is diagnosed as a recurrent respiratory infection due to some anomaly. Now, this can infection in the lower lobe or of the right lobe of the lung, and then staphylococcal pneumococele, or it may be due to congenital adenomatoid malformation, or it may be a sequestration. It turned out to be a sequestration with aberrant artery arising from the aorta. Most of these intralobar sequestrations and extralobar sequestrations have the origin of the arterial supply is from the aorta pulmonary artery as it is in normal lung tissues. And ultimately, of course, this can be removed by doing a thoracoscopy. And then we have removed these things by thoracoscopy. There's an arterial supply to the lower lobe arising from the aorta. So these are things that also produce a recurrent attacks of infection. And then, of course, we have been repeatedly being told that aspiration is the main cause of recurrent attacks of respiratory infection. Another cause of aspiration is, of course, the sliding of the stomach into the thorax. Either it may be a simple sliding hernia, where you can see the whole stomach is herniated up along the esophageal hiatus, or only one portion of the stomach might get inside. That is called the rolling type of hiatus hernia. Now, this is the one in which the fourth one, in which the whole stomach is herniated upwards in a mentally retarded children. By and large, most of the aspiration pneumonias, recurrent aspiration pneumonias do happen, as Dr. Anthony said, in mentally retarded children. This fourth boy was mentally retarded. All these things can be surgically being corrected. Nowadays, by laparoscopy, you can do the top, and then you can combine it with fundoplication so that there is no future gastroesophageal reflux. Now, severe gastroesophageal reflux getting aspirated into the trachea can cause recurrent respiratory infection, can cause sudden infant death syndrome, and then various other problems. With the advent of laparoscopy, now children in whom there is a grade 5 gastroesophageal reflux, this is entering into the trachea and producing a recurrent respiratory infection. After you have tried medical methods of management, if there is no improvement in the medical methods of management, surgery can be done very well by laparoscopy, and you can see the complete fundoplication that has been done by a laparoscopic procedure. Even in infants, laparoscopic procedure can be done. Nissen's fundoplication can be done, and this Nissen's fundoplication that's being done is floppy Nissen's fundoplication. Floppy in the sense it's not made, because earlier the problems of this Nissen fundoplication was 30% incidence of dysphagia. Now the dysphagia is not there because of this. Now, aspiration pneumonia is also common in, see, when you have more number of children with the tracheoesophageal fistula and esophageal atresia or alive, you are going to have more number of children with the recurrent aspiration and pneumonia. Now, these children, what happens is there is a gap between the upper pouch and the lower pouch of the esophagus, and therefore the lower esophagus is pulled up and anastomosed with the upper pouch. When it is done, the angle of hiss is essential for the prevention of gastroesophageal reflux, and then is not there, the whole contents of the stomach, as the stomach contracts, get aspirated inside. Now, the treatment again is doing a fundoplication, but technically it's slightly different because the intra-abdominal length of the esophagus is very short, and therefore you have to create an intra-abdominal esophagus by borrowing it from the stomach and then do a fundoplication later. Procedure. So lastly, I'm not talking much about the congenital adenomatoid malformation and foreign bodies, etc., and other conditions. I stop with this because we have got many more other conditions to be done. Achalasia cardiae is another cause of aspiration pneumonitis. It is surgically corrected by Heller's myotomy with fundoplication and can be done by laparoscopy. Again, you can see the esophagus is grossly dilated and then the child gets aspirated. By and large, many of these achalasia cardia, because the children are in milk feeds, they are not diagnosed early, they are diagnosed quite late when a solid food is started for the child inside. Now, by the time the child goes in for repeated attacks of respiratory infection, and very often they are treated as a gastroesophageal reflux. Now, you have to have in mind the possibility of the Heller's myotomy, and then this is always combined with the fundoplication to prevent future gastroesophageal reflux. Non-operative methods like dilatation with a balloon or Botox injections, etc., the results are not predictable. Whereas Heller's myotomy gives excellent results with the child and followed by this. So, so in children with recurrent respiratory infections, apart from medical causes, surgically remediable causes must also be kept in mind. Thank you very much.
Thank you, sir, for that very, very lucid and I think you repeatedly put all of us and the postgraduates to shame by the meticulousness with which the presentation is made and the volume of data is compressed into such easily understandable slides with excellent illustrations. Thank you so much, sir. Are there any doubts or any comments from the panelists?
Always experience makes us learn so many things which will not be given in books. Listening to stalwarts like him, I think we should have more of small capsules from sir or from great people like sir.
Well said, sir. Well said. We are blessed. Thank you so much, Professor Sir, for being with us and highlighting the surgical remediable process for recurrent respiratory infections. We'll definitely make an effort to keep these DDs in our mind. Thank you so much, sir. Dr. Sashi Anand, are you ready?
Yes, sir.
Yes, you can share. Dr. Ravikumar sir, can please stop screen sharing.
1 minute.
Thank you so much, sir. Good night.
Good night, but I'm not able to switch it off.
Dr. Sashi?
Yes, sir.
Yes, please. We'll have now to go like Rajdhani Express. We have 3 more presentations. Dr. Sashiana?
Yes, sir. 1 second.
Dr. Chidambaran?
Yes, sir.
Dr. Chidambaran, are you there?
Yeah. Yes.
Yeah, be ready, Ma. You'll be next.
Okay, sir.
Yeah. Make sure there is no glitches from your side. Be ready to present.
Sir, my slides are visible, sir.
Yes, perfectly, Raja. You're visible and audible. Please present. Yes.
Thank you, sir. Thank you, all my seniors and my dear colleagues, and especially thank you, Ashwath, sir, for giving me this opportunity. I'll be presenting a small case. 6 months back, we encountered a 6-year-old boy with cough for past 4 days, breathing difficulty for past 2 days, and fever for past 1 day. But if you ask the mother about the history of presenting illness, she would always say like she used to have cough and breathing difficulty on and off, sir. It will be waxing and waning. If you give some medications, it will go off, and most of the times he'll be on nebulizations, and a few episodes of inhaler therapy also has been tried. But on probing the history, the child had a lot of past history. He was second born to non-consanguineous couple with birth weight of 3.8 kgs. He was well until 1 month of age. Around 37 days of life, he had severe watery loose stools with a significant weight reduction up to 2 kgs. He also had severe cough during the time and nebulization was given. At the time, CMPA was suspected and endoscopy was done even during the infancy period, and biopsy was also done. So the proctosigmoiditis. He was started on hypoallergenic formula feeds. He had frequent V's associated lower respiratory infections, like 5 to 6 episodes per year, requiring treatment on OPD basis. His serum IG is always elevated. At the 5th month of age, he had hepatosplenomegaly, and they have done flow cytometry. Like CD3 plus CD8 and cytotoxic cells and NK cells were high, and CD3 helper cells, CD19 B cells were low, and T4 T8 ratio was also low. He also had recurrent bloodstream infections, proven bloodstream infections, and Klebsiella and then Enterococcus during 6 months. Had CMV sepsis, CMV IgG was positive, and urine CMV was more than 1 lakh copies. Started on ganciclovir given for 6 weeks. And during an episode of V's and loose stools, ANA-IF was done. It was positive, and he was treated as autoimmune enterocolitis with IV immunoglobulin. He also had a development delay, started to walk at 4 years, and he bisyllables by 4.5 years. Now he studies in class 1, and scholastic performance was good as per the parents. 2 years back, he also had seizures, unconsciousness, and bluish discoloration of lips, and for a few minutes, and given levetiracetam for 10 days and stopped. MRI brain done on the time showed right hippocampal atrophy. On September 2022, he was admitted in our hospital with viral pneumonia. Human metapneumovirus was positive in the nasal swab, and viral myocarditis, treated with methylprednisolone and other supportive care. On examination, child had features of failure to thrive, like hyperextensible joints, sparse hair, dry skin, eczematous skin. Weight was 11.3 kgs, 6-year-old, and height was 100.3 centimeter. And he was tachypneic. When I saw him in the emergency room for the first time, he was literally gasping for breath, and there was bilateral V's and occasional threats. Saturation was around 75 to 80% in room air, and abdomen was distended, and hepatosplenomegaly was noted. External genitalia was normal, and tachycardia was there. Had features of shock. So we treated him with inotropes and IV steroids and HFNC. Investigations for pulmonary tuberculosis negative, and in view of multiple admissions, they have done HIV previously. Forgot to mention it was negative. In view of multiple admissions and symptomatic from the infancy, whole exome sequencing was sent for consult with clinical geneticists. Child becomes sick here. Notable point is when we taper the oral steroids, child becomes sick. He is gasping. I mean, he becomes tachypneic. Some form of steroids he needed all the time. Child was on home oxygen for past 2 months. So this was a whole exome sequencing. It showed a FOXP3 gene defect, which is like IPEX syndrome. It was X-linked recessive immune dysregulation, polyendocrinopathy, and enteropathy. So he's been referred to Dr. Revati ma'am in Apollo Chennai. He was on IG infusion for past 5 months, 5 grams monthly once, and he has got a fully matched HLA donor, and child undergone HSCT 2 months back and doing well on follow-up.
Thank you, Dr. Shashi. Dr. Gauri Shankar, sir.
Yes, as we had, like, can we go to the past history? Really nice. Thanks, ma. Like, when a child gets into a problem early in life, needing admission, this child had weight reduction, GI symptoms, then also has respiratory infection, also has other system involvement with enlargement of internal organs. So, you know, some form of immune deficiency has been there. Probably, like when we say that, many times we may not see the parents once again because we tell them something which they are unable to understand. And like only when they know the gravity of situation, the need for investigations further, which are going to be costly, treatment is going to be costly, like probably we can save them from turmoil like this. It is a doctor's nightmare to treat children who comes with 75, 80 without ICU. It becomes a treating pediatricians nightmare. You cannot refer them when the child is really sick. You need to make them better. You need to give them higher antibiotics. So always a team effort. And this is one thing which I want to tell all the people who are in this program. Any problem at any time when you face dealing with any problem, especially respiratory issues, almost all the pediatric who are oriented to pulmonology in our state will be willing to help you with WhatsApp. Even with WhatsApp image, we are able to tell what next, rather than like you being alone in a difficult situation. You can get help from us. Don't feel shy. That is number one. And none of us have anything against you when you're going to call us and ask us for help. We are not going to think short of you. Every case, difficult case, is difficult even for us. We are also in the same situation. Don't think of us as like high above. We are in the same like wavelength as you are. Don't feel that we are very high and you are low. Definitely not. We are always learning every day, and a difficult case for you is also a difficult case for us. We make the same mistakes. Probably the amount of mistakes what we make is less. This is what I want to tell all those who are in this platform, either Anthony or myself or Chevabalan. Like, we are all like open to like discussing a case when you have a difficulty. That's all from my side.
Thank you so much, sir. Very, very briefly, one comment that Dr. Shashi made, very interesting comment, was every time the steroids were tapered, the baby used to start becoming hypoxemic. Is there any special connection between this particular immunodeficiency syndrome and steroids, or was it working on some interstitial pathology? How do we explain that finding, sir?
Probably, like, definitely they are going to have an interstitial. Yes, like steroids are going to cause, steroids are going to reduce the inflammation, and they are going to pick up immune deficiency. They are going to pick up viral infections right and left, and most common is going to be a viral, and it is going to cause an interstitial pneumonia. For that, steroids will definitely help them to walk to the grave. So definitely, you give them steroids, they are going to have some improvement.
Thank you. Thank you for that input, sir. Thanks, Dr. Shashi, for presenting a very, very rare case and a very beautifully presented workup and excellent slides with lots of information. Thank you so much.
Thank you, sir.
Thank you. Can we have Dr. Chidambaran's presentation next? Dr. Chidambaran?
Yes, sir.
Yeah, you can start screen sharing this.
Are my slides visible, sir?
Just briefly, Dr. Priyadarshini and Dr. Rupashri. Dr. Rupashri and Dr.
Yes, sir.
Priyadarshini, both of you are around, ma?
Yes, sir.
Yeah, Dr. Rupashri next, followed by Dr. Priyadarshini. Thank you.
Okay, sir.
Dr. Sorry to disturb.
Good evening, all. I'm here to present the case child B, 1.5 years
Raja,
old
you
child.
have to speak into the mic and start having screen on the full. Please use the screen share option.
Yes, sir. Are my slides visible, sir?
Your slides are visible, but your voice is not very clear. You need to speak into the mic or probably increase the volume.
Yes. Child B, 1.5 years old female child, third born out of non-consanguineous marriage.
Dr. Chidambaratanu, I repeat,
Yes,
your voice is not very audible, Raja. It's not clear. Please speak into the mic and start screen sharing.
yes, sir.
Slideshow mode, slideshow mode.
Is it now visible, sir?
It's visible. If you have difficulty, you can present like this. No problem.
Yes, sir.
Yes.
A child B, 1.5 years old female child, third born out of non-consanguineous marriage, presented with cough for 1 week, which is insidious in onset, dry in nature, no aggravating or relieving factors, fever for 1 week, high grade, intermittent, relieved with medications, active during interfebrile period, complaints of breathlessness for the past 4 days, insidious in onset, progressive in nature, no aggravating or relieving factors, history of recurrent respiratory tract infections present, history of inadequate weight gain as per mother. No history of any feeding difficulties, forehead sweating during feeding, condition of lips or extremities. At 3 months of age, child similar episode for which child was taken to a hospital where they have diagnosed it as a congenital heart disease and was started on syrup furosemide and was advised for surgery. Child lost follow-up there and syrup was continued for the 1 year. 3 months before, child went for a nearby camp for follow-up where the dosage of furosemide was increased and the spironolactone tablet was added. 1 month before, child again went for the camp where sildenafil tablet was started. Antenatal, natal, postnatal history was uneven. Developmental history, child had a global development. And immunization history, only birth dose of OPV and BCG were given. Clinical features on general examination, child on nasal prongs with flow of 2 liters per minute. Child is alert, active, and afebrile. Pallor present. On head-to-toe examination, child was having a brachycephaly, open anterior fontanelle of 2 x 2 centimeter, depressed nasal bridge, mongoloid slant, epicanthal fold, low set ears, open mouth, protruding tongue, pectus carinatum, brachydactyly, clinodactyly, joint hyperflexibility, rocker bottom feet, single caveolate spot over the right thigh. In vitals, pulse rate of 130 per minute, regular in rhythm, normal in volume, normal character, no delays, no all peripheral pulses felt. In respiratory rate of around 50 per minute, the retractions. BP of around 90 per 60 millimeter mercury between the 50th to 90th centile. Temperature normal. Anthropometry, child had severe acute malnutrition with microcephaly. Systemic examination. On CVS, first heart sound and the second heart sound are present in all areas with a loud P2 in the pulmonary area. A loud, harsh, blowing pansystolic murmur of grade 4/6 heard with maximum intensity over the left lower parasternal region. On respiratory system, bilateral air entry present, bilateral crepitations present. Per abdomen, soft and no organomegaly felt. CNS, hypotonia is present over the all 4 limbs. On investigations, total count of 21,000 with polymorphs of 44 and lymphocytes of 49% and mixed of 16%. Platelet of 2.38 lakhs. RBC indices with a normal with the hemoglobin of 10.5. CRP 50 milligram per deciliter. RFT serum electrolytes were normal. Echo showed large 1 centimeter subaortic membranous ventricular septal defect noted in predominantly left to right with moderate to severe pulmonary hypertension. Thyroid function tests were normal. Karyotyping for the Downs were awaited. This was the X-ray of the child. Shows bilateral hyperinflation. Bilateral infiltrates present with predominant right paracardiac infiltrates. Cardiothoracic ratio could not be assessed. Moving to the differential diagnosis. Initial diagnosis was kept as bronchopneumonia with congestive cardiac failure due to congenital heart disease, severe acute malnutrition with recurrent infections, aspiration pneumonia, immune dysfunction associated with Down syndrome, and tracheoesophageal fistula associated with Down syndrome. Diagnosis: bronchopneumonia, acyanotic congenital heart disease with subaortic membranous VSD with severe pulmonary hypertension, chromosomal aneuploidy, possibility of Down syndrome, global developmental delay, and severe acute malnutrition. Treatment: initial.
We don't need to go into the treatment part, Raja. You can leave that alone for the time being.
Okay,
Dr.
sir.
Anthony, can you please tell us why Down syndrome children need more attention with respect to respiratory tree? Is that only because of the association with congenital heart disease, or is there something else which makes them predisposed? If we have to follow, because it's such a common condition, how do we take care of the respiratory health?
The respiratory part, like these children, because of hypotonia, like, they can have feeding issues, and risk of aspiration is also quite high with these children. And other thing is they have problems with their upper respiratory tract as well. These children, significant proportion of them can have, because of the anatomical structure of the upper airway and, the falling backward of tongue due to hypotonia and pharyngeal hypotonia and adenine enlargement, these children can have, obstructive sleep apnea. And therefore, it's important whenever these children come, it's important to ask for, recurrent respiratory tract infection, any signs of, aspiration. And if there are any suspicion of aspiration, you have to evaluate for aspiration. And also, we have to ask about snoring, because most of the times, we don't give importance to sleep. In this particular situation, we have to do that, because the child has got snoring. If the child is not sleeping properly, probably the child might not, it might aggravate. Sleep problems can aggravate the learning issues with children with Down syndrome. Therefore, it's recommended, in all Down syndrome, they should have at least, sleep evaluation. And, in developed countries, they do sleep study at 4 years of age for children with Down syndrome. And therefore, these are the issues, upper airway issues, and risk of aspiration. Because of congenital heart disease, they can also have recurrent chest infection. And other thing is, we have to treat the whatever heart disease early, because their propensity to develop pulmonary hypertension early and going for ECG measures is also quite high. Therefore, nowadays we do screen all children for congenital heart disease at birth itself, in the first month of life itself, and intervene early, because these children, at risk of developing pulmonary hypertension early. And recurrent respiratory tract infection is an issue with these children. And other thing is, we need to ask about sleep in children with Down syndrome, and if possible, do a sleep study at around 4 years of age.
Are they immune deficient in the true sense of the word, Dr. Anthony?
Sorry?
Are they immune deficient in the true sense of the word? Do they have specific immune deficits which predispose them to recurrent respiratory infections? Or are they mechanical and cardiac issues mainly?
I think, as far as I know, they can have hematological issues, and, but I think the upper airway issues, I feel, is a more important issue, especially with the Down syndrome, because it has to be identified early and treated early. And other thing, practical thing is, whenever we send these children for, surgery, is important to, assess for axial, stability as well, because during, surgery and airway maneuvers, there is a chance, if the atlantoaxial subluxation is there, risk of, spinal cord compression, child might going for parapheresis. Therefore, that's another point we have to take into consideration. And I've not seen children having they might have subtle immunodeficiencies, but I've not seen major immune issues with children with Down syndrome.
Thank you.
Dr. Ashwath, can I add?
Dr. Chidambaram,
Can I add one thing?
Very lucid, very nice. Dr. Gauri Shankar, you want to add something, sir?
Yeah,
Please.
superoxide dismutase is 150% of the normal, but it does not do its function properly. So you have repeated, you are asking about whether there is any problem with the immune function.
Absolutely.
Your superoxide dismutase level is high, but it does not do its function, so the organism does not get killed. Thank you.
Thank you so much for that tidbit, sir. Thank you, Dr. Chidambaram, for that very brief and elegant presentation. Can we have Dr. Rupa Sri next?
Yes, sir.
Yeah, please.
Good evening, everyone. I would like to thank IAP TNSC for giving me this opportunity to present this interesting case in this forum in front of experts. Myself, Dr. Rupa Sri, a postgraduate, I'm presenting this case on behalf of pulmonology team ICH. So today I'm going to present a case with uncommon threats, that is exploring an unusual manifestation of a disease with multi-system involvement in an infant. So a 6-month-old girl child who was second born out of non-consanguineous marriage, whose birth weight was 2.8 kg. Her antenatal and postnatal history were not significant. Baby was immunized till 1.5 months of age, and she is a developmentally normal child. Since 6 months of age, child had 3 admissions so far, one at 40 days, then at 2 months, then at 5 months. In all these admissions, the chief complaints were cough, fever and breathlessness. And for all these admissions, the child needed oxygen support, nebulization and antibiotics. An investigation done at the time didn't reveal any sort of a primary immunodeficiency. ANC and ALC counts were normal. At 6 months of age, the child had fever for 20 days with minimal abdominal distension, and as per mother history, the baby was not gaining adequate weight, for which the child was evaluated elsewhere. Initial investigation had found to be negative, except urine culture showed some Klebsiella pneumonia growth. Echo was normal. USG abdomen was done, which showed minimal ascites, mild hepatosplenomegaly, and there were multiple hypoechoic lesions in both lobes of liver, spleen and pancreatic head. Followed by the CT abdomen and pelvis was taken, which revealed well-defined heterogeneous extrahepatic lesions in head of pancreas and para-aortic nose, and there were also some suspicious radiolucent lesions were present in left iliac bone, then in L1 vertebra, and in left femoral neck. So with all these investigations, they were more in favor of malignancy rather than infective etiology. Then child was referred to ICH for further management. Here investigations were done, and chest X-ray showed a heterogeneous opacity in right lower lobe of lung, and CCT abdomen was done, which showed evidence of multiple peripherally enhancing hypodense lesions in head of pancreas periportal region, and there were also micronodules in liver parenchyma, and there were multiple subcentrimetric nodes in para-aortic region and lytic lesions in left iliac vein and left neck of femur. CT chest were found to be normal. So with these investigations and imaging, we considered the possibilities of malignancy, mainly ALL, neuroblastoma, but there were not any suprarenal masses were present. Langerhans cell histiocytosis was considered as child had seborrheic dermatitis and with multiple lytic lesions involving multiple organs. And the second possibility was inborn errors of immunity, as child had recurrent infection with or without malignancy. So further we worked up by doing a PET CT, which revealed metabolically active lesions in left clavicular, bilateral posterior triangle in abdomen, pelvic and left inguinal lymph nodes showed central necrotic changes, and there are also multiple hypodense lesions noted in liver, spleen and also in proximal part of pancreas. There were also multiple lytic lesions in sphenoid bone, manubrium sterni, right 6th rib and L1 vertebra, left iliac bone and in shaft of left femur. Then we obtained the hematologist and pediatric surgeon opinion. As per their opinion, we did germ cell tumor markers and 24 hours urinary VME, which were negative. And then bone marrow aspiration was done, which was not suggestive of any malignancy. Finally, we did liver biopsy, which showed epithelial granuloma with extensive caseation. The impression was caseating granulomatous inflammation. So until that time, we didn't consider TB as a possibility for all these manifestations. Then in pulmonology, Manto was done for this child, which was strongly positive, more than 20 mm. And contact tracing was done. Both parents and grandparents were screened. Both of them were negative. Chest X-ray was done, which was not suggestive of TB. Gastric lavage CB-NAT was negative. Liver biopsy was not sent for CB-NAT as we didn't consider TB as possibility. Then the child was started on ATT and pyridoxine. Currently, the baby is doing well with a weight gain of around 800 grams in past 1 month. As child had this disseminated TB in infancy without any known contact, we planned for further additional evaluation. Immunoglobulin profiles were sent, which were normal, and nitroblue tetrazolim test was planned in view of TB and neutrophilic leukocytosis. Genetics were sent for Mendelian susceptibility to mycobacterium disease, and report is awaited. So final diagnosis is this is a case of clinically diagnosed disseminated tuberculosis with lytic lesions in bone mimicking malignancy. On literature search, there was a case which was published in October 2022 as a case similar to our case, in which there was multiple lytic bone lesions mimicking LCH, a case of infantile Mendelian susceptibility to mycobacterium disease due to STAT1 deficiency.
Thank you. That was
sir.
the wow presentation, Dr. Rupashree. Very briefly, sir. Gauri Shankar, sir.
Definitely, this child had started at 2 months and like has progressed to multi-system. Probably like my first diagnosis, as you had put it, everything was right. And when we have a peripheral node, probably like I will not do a liver biopsy. I definitely gone in for a cervical node biopsy, as the PET scan said, like posterior cervical region. Number 3, definitely screening of parents normal, but because in retrospect everything started from 2 months, probably this could be a perinatally transmitted tuberculosis, which has evolved into a system in this child. So this is what I can say, but this is my theory, but like subject to correction with the results from the genetic studies.
Is it possible that the child has a primary inborn error of immunity with BCG-osis, sir? Is that a possibility rather than an acquired TB?
BCG scar was normal. Axillary node was not there. So without that, probably I will not think in terms of a BCG-osis.
Okay, sir. So are all caseating granulomas tuberculosis, sir? Because repeatedly CB-NAT is negative, there is no contact.
No, CB-NAT they have not done, but if they had done, they would have definitely picked out like if it is going to be either BCG-osis or if it is going to be MTB. But CB-NAT was not done because it has come to pulmonology after the workup was done, because there was caseating granuloma. If they had seen earlier, definitely they would have asked for it.
Gastric lavage, it was negative, and the liver, it was not done. Am I correct, Dr. Rupashree?
Yes, sir.
So my question was whether all caseating granulomas can be presumed to be tuberculosis in our country, sir. Are there any differentials for that particular pathology which is not TB?
I am stumped by this question.
Okay.
I really do not know the answer. For me, common things common, and that's it.
So we are left with one more case discussion. Thanks, Dr. Rupashree, for that completely bamboozling case and very, very well worked up and presented. Thank you so much, ma'am.
Thank you, sir.
Dr. Priyadarshini?
Yes, sir.
You are the Jimmy Anderson. You stand between Australia and England. You stand between us and our dinner. Go to it, ma'am. All yours.
Yes, sir. Are my slides visible, sir?
Not yet, Ra.
Yes, ma.
Yes, perfect.
Good evening, everyone. I'm
Can just go to the PowerPoint.
President
PowerShare mode.
Dr.
Sir?
Priyadarshini, sir is making the suggestion that you can choose the slideshow presentation option.
Right at the top, no, you have the little triangle. No, you can just click on. Not there. The third button at the top. Yeah, present on this device.
Okay.
It's okay, ma'am.
Let me proceed.
F5. F5 type.
Yeah, go ahead, go ahead. Otherwise,
Okay. This case is a 4-year-old male child, first born out of non-consanguineous marriage, who presented to us with complaints of cough for 7 days, fever for 4 days, increased work of breathing for the past 1 day, and also the mother gave the history of a poor weight gain. History of presenting illness: child was apparently normal before 7 days, and then he developed cough of 7 days, which was insidious in onset, present more during the daytime, no postural variation, no aggravating or relieving factors. Sometimes the cough was followed by post-nasal vomiting. Next, fever was for 4 days, which was high grade, intermittent, not associated with chills. It was relieved by paracetamol syrup. The child was dull during the interfebrile period. Next, for the past 1 day, the child developed fast breathing with chest indrawing, which is not relieved by inhalers. It was also not associated with noisy breathing. The child, there was history of lethargy, and also there was a history of poor weight gain for the past 1 year. Past history: the child had history of recurrent every 3 months, each lasting for at least 7 days in the past 1.5 years. Out of these 3 episodes required hospitalization. First admission was 2 months back at a private hospital for bronchopneumonia. There he was treated with nasal oxygen nebulizations and IV antibiotics for 5 days. Second and third admissions were at our hospital for similar complaints. Similarly, he was treated with IV antibiotics for 5 days and discharged with reliever and preventer bronchodilators, inhalers. Other episodes were treated on OPD basis at various hospitals. There was also a history of ICU admission for bronchopneumonia at 1.5 months of age, where he required only nasal oxygen, IV plus oral antibiotics for 10 to 14 days. He had no history of congenital heart disease. Antenatal and natal history was uneventful. There was no history of TB or COVID contact. There was no history of any sudden unexplained death in the family. The child was immunized up to age according to national immunization schedule. No additional vaccines were given. He attained developmental milestone appropriate to age. Clinical features: at admission, he was IV paracetamol and IV antibiotics. The child had pallor. There was no generalized lymphadenopathy or pedal edema. Head-to-toe examination: there was no dysmorphic facial features. Low set ears alone was present. Tonsils were present. BCG scar present. No chest wall deformity was seen. Systemic examination: upper respiratory tract examination was normal. Respiratory system: on admission, the child had retractions, bilateral V's, which was relieved with nebulizations. There was no obvious chest wall deformity, kyphosis, or scoliosis. Abdomen: no organomegaly was present. CVS and CNS was normal. Anthropometry: weight was 11.4 kgs, which was less than 3rd percentile. Height was 99 centimeter, which was between 3rd and 50th percentile. Weight for height percentage was less than 3rd percentile, which indicated severe acute malnutrition. Next, the differential diagnosis for child with recurrent pneumonia. For this child, we had foreign body inhalation, malnutrition with recurrent infections, GARD, pulmonary tuberculosis, congenital heart disease, congenital anomalies of upper or lower respiratory tract, then immunodeficiency, which could be either primary or secondary, and then at last cystic fibrosis. Investigations done where CBC showed anemia 8.2 HB. The total count was elevated with lymphocytic predominance. CRP was also elevated 31.5. Chest X-ray showed bilateral lower lobe pneumonitis. Respiratory panel PCR showed Streptococcus pneumoniae and pan fungal positivity. Specific investigations for GERD, we did barium swallow, which showed normal study. The investigations for tuberculosis was also not negative, Manto negative, and then sputum, AFP, and gene expert were negative. Echo done to rule out congenital heart disease was showed normal study. For foreign body and congenital anomalies, we did HRCTHs. It showed only consolidation of infective etiology involving left upper, right middle, and bilateral lower lobes. For immunodeficiency, immunoglobulin profile and flow cytometry done showed normal study. At last, we did whole exome sequencing, which showed immunodeficiency 45, which was a homozygous mutation. At last, diagnosis was immunodeficiency 45 disorder, which is a homozygous mutation involving chromosome 21q deletion. This immunodeficiency 45 is an autosomal recessive immunological disorder with specific clinical features. These patients may present with life-threatening respiratory infections with COVID-19 or influenza with severe adverse reactions like meningoencephalitis and hemophagocytic lymphohistiocytosis to live attenuated viral vaccination. Lab studies showed impaired response to alpha interferon, impaired type 1 signature after stimulation, and heightened vulnerability to multiple viruses in vitro. Pediatric hematologist opinion was obtained. He has advised for IVIG infusion 5 grams every 6 weeks for next 3 months. At present, child is on antibiotic prophylaxis and antifungal prophylaxis. Now he is symptomatically bitter with no new episode of respiratory infection.
Thank you, Dr. Priyadarshini. A million apologies. I think I missed out one presenter, Dr. Vaijayanti from Rainbow Hospital. Once she is presented, we can wind up. Is that okay, Dr. Thiru?
Yeah, please go ahead. Yeah.
Dr. Vaijayanti, you can present because the case scenarios are very similar to what Dr. Priyadarshini is that we can have some final summing up comments and we can close the show. Dr. Vaijayanti?
Yes, sir.
I'm so sorry I forgot about you, ma. I'm really sorry.
Am I audible, sir?
Yes, ma, you are. Please.
Is my screen visible, sir? Is my screen visible, sir?
Yes, ma'am.
A very good evening to one and all. I'm here to present a case of recurrent serious bacterial infections. An 8-year-old female child presented with cough and cold for 10 days, fever for 4 days, vomiting for 2 days, and fast breathing for 1 day. The cough was insidious in onset with 10 days duration, wet-sounding cough with no diurnal or postural variation. Fever was acute in onset, high grade with no chills or rigors. Vomiting was 1 episode, non-bilious or non-projectile. There was fast breathing for 1 day. No history of chest pain, hemoptysis, weight loss, rashes, or skin infections. On probing the past history, we got a pattern of multiple admissions, needing hospitalizations and needing IV antibiotics. A history of enteric fever at 1 year of age, history of pneumonia with oral candidiasis at 1.5 years of age, history of skin infection with lymphadenopathy at 7 years of age, and history of dental infection with pneumonia at 8 years of age. On probing the family history, we got to know that the child was born of second-degree consanguinity with death of a younger sibling at 2 years of age due to suspected bacteremia or sepsis. And also, there was history of multiple infant deaths in the paternal family. The child was vaccinated as per national immunization schedule. No history of contact with open TB case. History of atopy was present. On clinical examination, the child was found to be tachycardic, tachypneic, with a room air saturation of around 89 to 90. The child was well thriving with a weight of around 23 kg, more than 25th centile. There was oral thrush which was present. Examination of RS showed bilaterally decreased air entry, significantly more decreased on the right side. Bilateral crepitations were heard. Cardiovascular system was normal. And abdomen examination, there was a tender hepatomegaly. CNS examination was also normal. No meningeal signs were seen. At this point, it was clear to us that we are dealing with a case of primary immunodeficiency because the child has had recurrent serious bacterial infections needing IV antibiotics, and also there is a family history of multiple infant deaths. So since this was predominantly bacterial infections, we were thinking of DD in the terms of either chronic granulomatous disease, common variable immunodeficiency, or hyper IgE syndrome. On further investigations, this was a CBC profile of the child. The child had anemia on admission. There was significant lymphocytosis The ANCs were always high. There was significant neutrophilia, and the absolute lymphocyte counts were always in the range of 2,000 to 3,500. There were a few episodes of thrombocytopenia in between. The CRP and procalcitonin were significantly elevated. The chest X-ray showed right basal consolidation initially, and subsequent X-ray showed a bilateral pneumonia with a left-sided pleural effusion. The CT chest, which was done later, showed a severe necrotizing pneumonia with multiple loculated and thick septated pleura. On further investigations, the organisms which were isolated were the blood culture was sterile, but the pleural fluid and the sputum culture showed a growth of Pseudomonas aeruginosa. And the pleural fluid gene expert was negative for MTB. The nasopharyngeal film array detected adenovirus, human rhinoentro, influenza A H1N1 2009, and SARS-CoV-2. And immunoglobulin levels were done initially, which showed raised levels of IgE and IgA. IgG and IgM levels were normal. Nitroblue tetrazolium test to assess the phagocytic function was done, which was negative. Further, we followed up with a lymphocyte subset analysis, which showed a reduction in the number of memory B cells and the class switch memory cells. The naive helper T cells were also reduced in number, but the other lymphocyte subsets were normal. A genetic workup was done, which showed immunodeficiency 71 with inflammatory disease and congenital thrombocytopenia. It is an autosomal recessive disease where there are defects in chemotaxis and defective T cell functioning. So the child is characterized with severe sinopulmonary infections, some inflammatory pathology, and recurrent skin infections, leukocytoclastic vasculitis also. So the child, this usually starts in the early childhood, and they are characterized by severe infections, which may cause death in the early childhood. So this particular child was treated with appropriate antibiotics, and IVIG was given. Cidofovir was given in view of adenovirus in an immunodeficient child, and VATS was needed for the necrotizing pneumonia with a thick septated pleura, which was converted to open thoracotomy later. The child was electively ventilated for 48 hours and subsequently extubated. ICD was removed on the post-op day 3. A repeat imaging showed resolution of the lung findings. The patient was discharged well, and the patient was discharged to about the need for regular IVIG, Septran, and voriconazole prophylaxis.
Thank you so much. I think it's mind-boggling. Today's presentation has just highlighted the fact that we are sitting on a minefield of the undiagnosed primary immunodeficiency disorders, or the inborn errors of immune system, as they are called. Almost all the cases except the tuberculosis case were in some way related to the immune system. So that is quite frightening and enlightening at the same time. So since we are running out of time, can I have 2 or 3 quick comments from Dr. Gauri Shankar and Dr. Anthony on what are the common immunodeficiency disorders that present with recurrent respiratory tract infection, and what are the ones where the outcome is good? Because the general opinion is that these children don't do well unless they have a hematopoietic stem cell transplant, which is beyond the financial and physical reach of many children. Very, very brief comments, please. Thank you.
We are also learning. I'm also learning the last 2 cases. And whenever you have a child who has got a recurrent episodes, think of these possibilities. But genetics is not the end. And when you have a difficulty in diagnosing or treating cases, it has to be a team effort, because not a single test is going to help you out. Probably multiple brains can help how to move in a proper way in a particular child who has got repeated infections. It is still evolving. I'm also, knowledge is more. We are still trying to learn. I will not be able to tell a particular answer for your question. I'm sorry, because I'm still learning. The last 2 cases, it was news, like I'm learning. This is my view, sir.
Thank you. Dr. Anthony, before we wind up today's session.
I think for diagnosis of immunodeficiency, I think 3 things are important. The first is the pediatrician. It's not necessary the pediatrician has to be in tertiary care Could be in a primary care pediatrician. Only thing is he has to suspect, like in spur conditions, severe infections and persistent infections, unusual bugs, recurrent infection, and if it runs in families, these are the things. If it is there, he has to suspect, and better not to keep the patient with a pediatrician, even if it is in a tertiary care. I think, as you said rightly, the second important person is the person who will diagnose for you. You have to interact with the person who will diagnose for you. Simultaneously, you have to talk to the person who is going to treat, is going to be hematologist. Therefore, these three people are pillars for diagnosis and treatment. For me, the key is early diagnosis. Now we have a treatment. Therefore, I don't want a kid with hypoxemia on a ventilator. Therefore, these children cannot be cured. Therefore, pick them up early. That's the pediatrician's role, and refer early. And you interact with people who can diagnose and treat. And this can be done in the primary care itself. And look at the X-ray and look at the WBC counts. And there are situations where your lymphocyte subsets, immunoglobulins, counts, everything could be normal. If you suspect, there are conditions where everything could be normal, but you can have a diagnosis on genetics. And the first case I saw only VUS. Therefore, if it is VUS, you have to be, doubly sure what you are treating. It could be some other condition. Therefore, in VUS, don't take VUS as the particular diagnosis. It could be cystic fibrosis, sweat test. Therefore, and other thing is whenever you send for clinical exam, you give important terms. Don't just put PID. If you consider lots of differentials, put everything. Child with respiratory stress, persistent, or recurrent infections. I'm thinking in terms of all the possibilities, so that they can analyze it properly. Yeah, and VUS, you have to be very careful.
Thank you. Thanks for those excellent summaries, Dr. Gauri Shankar and Dr. Anthony. So, if there are no further questions or queries from my fellow panelists, I will wholeheartedly and thank both the panelists for being very patient with our queries and being very lucid with their responses and their answers. I again take the opportunity to thank all the presenters who have come up with brilliant presentations, trying to squeeze as much information as possible into as few slides as possible, and also my co-panelists on the IA4C panel for making it available. And a very big thanks to my dear friend, Dr. K. Rajendran, for keeping this program vibrant and keeping us all motivated. Thank you, one and all. Good night.
Thank you.
Over to you, Dr. Thiru.
Yeah, thank you very much. Another exhilarating session and very nice case discussion. So my thanks to Professor Ravi Kumar sir, Dr. Gauri Shankar sir, and Dr. Anthony for the discussion and all the presenters, and of course, last but not the least, Dr. Ashwath for being extremely patient both in front of the screen and also behind the screen. So thank you very much. And again, I think this month we are going to have the second by the end of this. Last week of Sunday. So hope to see you all then. Thank you very much and good night.
Thank you. Good night.
Thank you. Good night.